and thank you for coming to this satellite symposium sponsored by GE and Lunar iDXA and the role of imaging in managing obesity. My name's Alan Davis, and I'm Chief Medical Officer for General Electric. And I have a couple of declarations. Clearly, my salary, my pension, my shares are tied into the performance of GE. And secondly, some of the concepts that we talk about today are not products, and they may never be products. And certainly, some of the concepts have not been approved by any regulatory authority anywhere in the world and may well not be offered for sale. So the program today, a brief introduction about where we see obesity, and then Francois from the Nestlé Research Center in Switzerland is going to talk about metabolic variation and relationship to lifestyle change. Francois is a senior research fellow at NRC, and GE and Nestlé had a very profitable and fruitful, interesting research collaboration for the past few years. Francois did some research training in London. I think now, given the weather, he's happiest to be by the lake in Lucerne. And then it's very nice to welcome Professor Nick Wareham from the Medical Research Council unit, the Institute for Metabolic Science in Cambridge, who is taking a global look at central obesity and cardiometabolic risk. I won't take any questions after my presentation, but Francois and Nick have agreed to take questions immediately after their presentation, and we need to be out of here, I've been told, well before 2 o'clock if we can. The next session starts at 2. So why are we interested in obesity? This is from the Davos, it's the WHO data, and if you look at the likelihood of events happening and the severity in cost in trillions of US dollars, then there's not a lot we can do about acid price collapse, and there's certainly nothing we can do about China and a hard landing. But there's a lot we can do about chronic disease. And chronic disease probably costs somewhere between 70 and 80% of healthcare costs for most Western European countries, and is an increasing cost burden for the emerging world. Our vision is tied to healthy imagination because the issues around chronic disease and management and delivery of healthcare are around cost, access, and quality. And we have established a $6 billion initiative through till 2015 that is independently verified by a company called Oxford Analytica to reduce costs by 15%, to improve access globally to healthcare, whether that's in the US or whether that's absence of trained healthcare professionals in sub-Saharan Africa, and also to manage quality of healthcare. And that's not only between countries, but within countries. For example, in my native country, in the United Kingdom, there are very big differences in delivery of healthcare between the poorest and the richest areas of the country. But it's not just about technology. We're a technology company, and the technology is pretty, it's sexy, it's very attractive. But it's not just about the technology. What matters is innovation of implementation. And to do that, healthcare IT is clearly important to manage information. And we need to get more personalized with our medicine, if you like, to identify the phenotype more accurately. So if we accept that implementation of innovation is the challenge, then there are 3 examples. From the 70s, cancer screening was developed and has been successful. Stroke, the UK very recently changed the care pathway for the management of stroke. This was no new research, this was no new technology, but it was about training the public, training the paramedics, training the casualty doctors, and getting technology to the stroke physicians to administer therapy. And the challenge for the future is to stop disease progression from obesity, diabetes to cardiovascular disease. WHO figures 1 billion people are overweight in developed and developing countries. Diabetes is developing. You're very familiar with this. The WHO estimate 80% of stroke and heart disease is preventable. We must transform the way we tackle disease. And this is about a move to prevention. It's a different way of thinking about nutrition and, of course, education. So we propose a new care pathway for obesity and diabetes. This is an implementation innovation, if you like. We know, this is the Lorenzo data from 2003, that body mass index values in the intermediate range between 25 and 30, you might as well toss a coin. They fail to identify half the people with excess body fat. So it's an early visualization of body fat. This could be potentially a game changer. It puts the patient at the center of the management of disease. We can monitor therapy and lifestyle choices and induce a behavior change in the population. And importantly, using healthcare IT, developing concepts around the expert patient and home monitoring, reducing travel, we can save costs, improve outcomes, and stop progression to disease. The picture there is an organisation in Belgium called Mensana, who have a mobile unit they take to local hospitals and to elite sporting events. And they have some very nice information showing that taking the technology to the patient where they are or into the home is very productive in terms of reducing healthcare costs and getting better outcomes and better research. But people deliver change. The change is agreed through government, by policy. It's enabled by technology, but government and technology on their own are insufficient. There needs to be leadership, you need to build engagement, and you need the right organisation to deliver change through people. So our vision is for a transformation in the delivery of healthcare and the delivery of better healthcare more equitably at lower cost. I'm delighted now to ask Francois to come and talk about metabolic variation and the work that is currently continuing at the Nestlé Research Centre. We'll take questions after Francois' presentation. Thank you.